Blue Cross and Blue Shield of Texas is proud to sponsor events like the one you're about to see because we love to see Texans get involved in public dialogue and civic engagement.
Hi, everyone. My name is Shannon. I'm the Women's Health Reporter for the Texas Tribune. Thank you for tuning into this conversation on rural healthcare as part of the Texas Tribune Symposium on the Future of Rural Texas. I'm joined today by Sudip Bose, Leticia Rodriguez, and Representative James Frank. Thank you so much all for being here. Dr. Bose is an emergency physician at Pecos County Memorial Hospital in Fort Stockton and at Medical Center Health System in Odessa. He has become one of the nation's most experienced doctors in mass casualty, disaster care, and PTSD, and was selected as one of the leading physicians of the world by the International Association of Healthcare Professionals. Leticia Rodriguez is the CEO of Ward Memorial Hospital in Monahans. Previously, she served as CFO and Comptroller of Crane Memorial Hospital. She's a fellow of the Texas Hospital Association, former president of the Monahans Chamber of Commerce Women's Division, and the Texas Association of Healthcare Financial Administration. Thank you for being here. And last but not least, we have Representative James Frank. He has represented House District 69 since 2013. He serves as chair of the House Human Services Committee and sits on the Public Health Committee. Representative Frank was recently appointed to the House Select Committee on Statewide Healthcare Costs and the Health and Human Services Transition Legislative Oversight Committee. We're going to have some pre-submitted questions from the audience mixed in. But to start, I think it's hard to ignore the fact that we are 7 months into a pandemic at this point. And I wonder if Ms. Rodriguez, you wouldn't mind setting us up and telling us a little bit about the financial forecast we were looking at pre-pandemic and what the effect of the coronavirus has been on your and other rural hospitals.
Okay. So prior to the pandemic, every year we set goals for ourselves and how can we, do better year after year? What kind of services can we offer to the community that, previously we didn't have? And then, boom, comes March and, we're hit with this COVID crisis. So, of course, all the plans we had for this year had just kind of have gone out the window. Once that hit our organization, we had to strategize. And of course, it's how do we deal with this crisis? We formed a interdisciplinary team and just started the planning process. And of course, what we thought was going to be an influx of patients at that time, kind of didn't hit our area, but we were doing a lot of planning, trying to, of course, get the resources, the PPE. So we're dealing with so many different types of problems and pressures and things that, we didn't forecast that this year. Of course, then, surgeries, they said you got to put a hold on that. And so we lost a lot of volume coming in. People were being, asked, don't go to your healthcare facilities unless you have to. People were scared. So we saw a big drop in our census, ER census, inpatient clinic, of course, the surgery department. And so, thankfully, we had those subsidies to kind of carry us and carry us through to this day. Otherwise, it was just, as you know, rural hospitals, we suffer. We have negative margins as it is. And it was just devastating for us and, of course, many others.
Dr. Bose, a similar question to you. In different areas, we've seen the pandemic exacerbate existing structural problems. What has it been like for you during this time? And have you seen that dynamic play out in rural healthcare? In what ways, if so?
Yes, and thank you for having me on this. First of all, pleasure to be here. From the ground in the emergency room, I'm definitely seeing changes. So first of all, as she mentioned, the rural hospitals are struggling. I mean, and I'm not personally looking at the finances, but what I'm seeing is patients coming in, and you see the vulnerable populations. We've read about this, and we see it in the emergency room. Certain ethnicities, people who have more poverty. These are more vulnerable populations, and some of these are in the rural areas. So then when COVID hit, what happened was it became more exposed, even more so. So, you're hanging off a cliff by a dandelion stem, and then, COVID hits, and then all of a sudden you're seeing who's getting more sick, who's more vulnerable to COVID. And then when we have these patients, and many of them need ICU level care, because of other hospitals going on diversion, I'm having difficulty transporting them to the place they need to be, because we're in a critical access hospital, and then how do you get them to Medical Center Hospital in Odessa or somewhere else when those hospitals are on diversion? So it's challenging.
And diversion, do you want to just explain that for people who aren't familiar with that term?
Sure. So in the emergency room, when you take care of patients in somewhere like Fort Stockton, where I work, I also work at Medical Center, you stabilize them, and then you need to get them to somewhere with a specialist, because that doesn't exist in Fort Stockton. You're looking at the specialist here in the emergency department. You have to play orthopedic doc, OB doc, cardiologist, everyone else. So eventually you got to get them to another destination. But those hospitals after COVID aren't accepting. They're not accepting those hospitals. So you have to divert them somewhere else. So that's what I mean by diversion, whether you have to go all the way to Lubbock or even further away. This is a long flight for patients. It's long trips by EMS. The rural EMS already is serving so many people that are off the grid and so far away that it takes them days to even get to Fort Stockton at times. I'm seeing them a day or two after their injury. And then from there, I'm trying to get them to the next step, and that's a process as well.
Representative Frank, kind of same question to you about the impact of the coronavirus, but I wanted to ask you specifically about telehealth. I think that you had said that the lessening of some regulations and the increasing use of telehealth had been more positive changes stemming from the pandemic. Can you tell us why that is? And, what do you think is the role of telemedicine and rural health going forward?
Well, I mean, certainly there's been tremendous amount of challenges, as Ms. Rodriguez mentioned, financial challenges in rural health, particularly when you take out all the optional surgeries, so a lot of revenue influence or negative revenue influences. But I think you also have to look sometimes when you have challenges and when your organization is stressed, what are some of the good things that have happened? And I think several of the good things that have happened is the acceptance of telehealth and telemedicine, I think, is a huge upside for rural healthcare. At the end of the day, what we want in rural areas is access to healthcare. And with the incredible specialization that has happened in healthcare, really the only way to do that, you cannot have specialization in every single rural area. And so having access to the telemedicine is a real, I think, a big step for access to care in rural areas. I think the other thing that has been important is there have been a lot of, there is a lot of overregulation in the medical industry, in the hospital industry, from the federal government, from the state government, and anybody else that has a chance to regulate. Some of those regulations have been loosened during the pandemic, and we need to look and see whether those things are actually needed. It is amazing how many people in a hospital have nothing to do with taking care of the patient, but are simply moving, basically trying to work for the federal government, reports, and those kind of things we need to look at. They're not actually helping take care of the patient, but the hospitals are having to absorb those costs. And I think we need to take advantage of the fact that we've looked at that and see which of those things we can remove. So I think the telehealth, telemedicine, and allowing, essentially streamlining, removing the non-medical people out of the hospitals so that we can pay for the medical people to take care of patients.
A question from the audience here that's related to this. Charles asks, telehealth is looked at as a workforce solution to serve the healthcare needs of rural Texas. While everyone is focused on access, how are we evaluating the quality of that care? And, I don't know if Representative Frank, you want to take that, or if Ms. Rodriguez or Dr. Boise, you have thoughts on that?
That's a good question. I can take the first attempt at that. I'll tell you a real quick story here. I'm from Chicago before I ended up in Fort Stockton, and one of my friends, he ended up getting a traffic ticket, right? One of those cameras that catch you when you're driving. And, he gets home, he opens his mail, and he's like, what the heck? I got a ticket from a camera, and he was pretty upset about it. So what he did was he Xeroxed a couple of $20 bills and mailed that in. And he's like, okay, if I'm getting a ticket by camera, I'm Xeroxing some $20 bills and sending that in. And then a couple weeks went by, and he didn't hear anything. And then a letter came from the city. He opened it up, and it's a Xerox picture of handcuffs. And that's when he decided to pay the ticket, because he knew there was a human behind the technology. And that's the point I'm trying to make. So when you implement telehealth, telemedicine, telepsych, you need to have a human behind the technology, that human touch. You just can't do blanket technology. And that's one way you can guarantee quality. And we have to find that right interface.
No, I think you're right. And really, the telehealth, telemedicine is going to be governed by the same rules that it is now. I mean, how do you find good doctors and bad doctors now? Some are very good, some are bad. It's the same thing with telehealth and telemedicine. You're going to have some good and some bad, and the patients and the organizations that are running those activities are going to be creating the quality metrics that are used.
And we also have to hope that we don't get pockets of decreased care, because more providers feel like, oh, I can do this by telehealth, and there's nobody in proximity. So it's also finding that balance, in my opinion.
I actually also am hoping that it'll be a economic boon for some of the rural areas, because frankly, if you can live in a rural area, much less expensive and not nearly as crowded, safer probably in a lot of ways, you can actually you can practice medicine there as well, and provide it going the other way.
I'm just going to do one more question from the audience here. This is from Rodney. It's a pretty broad question. So again, anyone that wants to take this, please feel free to jump in. Rural hospitals are closing at a record pace all over Texas. What are the prospects for saving lives and maintaining health for those who live in rural counties as money from state and federal sources disappears? Maybe Ms. Rodriguez, we can start with you.
Yes. So yes, we are. You hear it every day. You hear it in the news. And so, I think with the COVID, like they mentioned, the telehealth, there's things that we learned from, what's been happening since March. But at the end of the day, I think, when you live in the rural areas, those providers have formed these relationships with these patients that in this community. So it's going to take a lot of change to adapt to a new way of, delivering care. And so, when you compare rural facilities with urban facilities, those are things that we're able to do very well. Connect with patients, connect, personally. Everybody knows everyone in our towns, their neighbors, their family members. And, how do we continue to provide those services and have the funding, to our facilities to make us still be able to deliver that quality care and remain and keep our doors open. We have a 25-bed hospital, a level 4 trauma center, ER, and we do a lot of good here. And when you're struggling financially and you're having to cut all these different services and even, surgery, the community is the one that lacks. The hospital is the lifeblood of the community. We can't attract new services. We can't attract new businesses to come in when you don't have a full-fledged hospital and thriving hospital.
Well, there's a number of things that have been done to try to increase the revenues out to rural hospitals, and we need to continue to do that. I think at the same time, both rural hospitals and really all hospitals are changing incredibly rapidly. There are so many procedures now that are done on an outpatient basis. So I think really hospitals themselves have almost switched in many cases, from hospitals to medical centers, where they're surgery centers. And I think the rural hospitals is just with the lack of volume, it makes it much more difficult to change. and it makes it harder to cover your costs. You buy very expensive equipment for many of these services. If you only have 10 patients that ever use that, it's a lot harder to pay for it than if you have 1,000. And so, there are some challenges, but I think many of the rural hospitals have done a great job of switching to more of a medical center than a hospital. And those changes are, I don't think, going to do anything other than accelerate over the coming years as technology improves and the like.
Challenging. I mean, from my perspective, from what I'm seeing in the emergency room, many of these guys are hours from like pavement. Not every place is near an interstate or can have access to the hospital at Fort Stockton. So once they get onto pavement, they're trying to come in, later. So I'm seeing the injuries a day later. And, as Leticia mentioned, sometimes, people are putting off things because of COVID. So imagine if you have 50, 100 miles to get to a rural hospital, and then that rural hospital closes, there's problems. I mean, we're talking hundreds and hundreds of miles to get to hospital access, which does, frankly correlate to increased mortality. And that's bad. And that has ripple effects all throughout America, because that patient in bed 4 I'm seeing is working in the oil field. And that's how America gets their oil. They're a desert worker, a rancher, a farmer, to food on the table. I mean, this is rural America, but anyone watching this in urban Chicago, New York, Washington, D.C., this is a huge ripple effect throughout America when you have increased morbidity and mortality because hospitals are closing.
I wanted to ask about staffing, but there's another audience question that kind of relates to it. So combining these two questions, Allison asks, in which specific areas of rural healthcare do you see the greatest need for healthcare workforce expansion and access to care in rural Texas? And just as an addendum to that, what do you think are the best ways to attract and retain specialists and other doctors in more rural areas?
I can take this one. I mean, I think like emergency medicine, which is what I specialize at, as is kind of an urban specialty in the sense that most of the training programs are, in big cities. You learn to take care of big city traumas, gunshot wounds, things like that. So getting those people to a rural region has challenges. So I think we need to incentivize that. And we talked about telehealth before, but I can't do my job without fantastic nurses. And, I can't thank the nurses enough. So I think using, the nurse force, that's going to help a lot. And nurses are amazing. I mean, from the basic nurse level to the NP level, they can hold down rural America. So that can help. Telehealth can help. I've told around ideas. I'm the EMS medical director in Odessa, Texas, for Odessa Fire Rescue. In certain places of Europe, there's physicians who actually go in the ambulances to people's homes. There's different ways you can get that access, and we just have to toil these ideas around in our head and figure out how to do this.
Representative Frank, Dr. Bose mentioned the role of nurses. Do you see lawmakers changing scope of practice or licensing requirements, for example, giving advanced practice registered nurses more leeway to treat patients?
I mean, that is always a challenge. I have been in favor of it. I think the more access you give to healthcare, the better. One of the question had to do with specialists. You're not going to have specialists in rural areas. What you need to make sure is that you have the access to the general medicine in the rural areas. And we need to make sure we have that, whether that's doctors, whether that's, to your point, a nurse practitioner. People need that entry into medicine where they can get an intelligent answer and then be moved to the specialties wherever those specialties are. But really, you're not going to have some very exotic specialist going to a rural area. There's not enough demand. What you've got to have is the general practitioners that are out there, and whether that's the doctor themselves, whether that's the nurse practitioner, or whether that's telemedicine, people in rural areas need access to healthcare answers as quick as possible. So, not just as quick as possible, quick and quality, both those things.
So some of the things that we have worked here at Ward Memorial Hospital and trying to bring those specialists to our area, it's hard to recruit them full time, you know. So what we've done is we've, you know, structured contracts or with whether it's cardiology, orthopedic, podiatry, audiology, and urology, and try to bring them in on a monthly basis, you know, and they stay really busy. And our community really appreciates that. They still have that full circle of care. They see their PCP in our clinic, whether that's the MD or a nurse practitioner or PA, and they make that referral to that specialist. Then that specialist sees the patient. They've got to go and do a procedure or something at Medical Center Hospital or RMC, then they do, and then they send that note back. And you know, that's that continuity of care. They still stay local, they stay in the community, and they get that access to care that they need.
I think one thing that would help is transports too, in my opinion, because, you know, there's one place in America and in rural areas that you can go for everything. I mean, broken bone, heart attack, stroke, everything. And that's the emergency room, you know, mm-hmm. Anyone, anywhere, anytime. It's open 24/7. And then when the emergency physician who's trained to take care of the first hour, few hours of any critical illness can get that stabilized, then we have to be able to transport to the next area. So, you know, I think the representative is correct. We cannot get a pediatric hematologist oncologist in a rural area. These specialists aren't going to happen. But what we can do is do the legislation or the resources so that we can transport them. Because as emergency physicians, we can stabilize. But then when I'm managing an ICU because I can't get someone out for 9 hours, that's a problem. So I think the transports will help, you know, resources into emergency medicine, resources into EMS, and that may be where we target instead of, you know, that pediatric hematologist oncologist.
Well, while we're on the topic of changes that could be made, maybe we can start with Representative Frank here. You know, what kind of changes do you see the state legislature making, or do you hope that they will make to improve quality or access to care in rural areas? And on the flip side, what could the federal government be doing more of or less of?
Well, ultimately, it comes down to money, making sure that we're funding it adequately. But I think beyond that, it is removing expenses. You know, not only do you not get paid a lot for Medicaid, you have a lot of paperwork. And so we have choices. We can either put a lot more money in, whether that's federal or state, or we can remove some of the costs that the rural areas are having to absorb, or all hospitals are having to absorb just to do the paperwork. And so I think, to me, that's on the resource side. The biggest thing we can do is obviously we can put more resources in it, but really isn't it also a good idea to remove the unnecessary expenses that aren't actually helping patients? You know, to me, that's the easy one because it actually doesn't cost more money. And so you remove any of those things that you can. Whether that will be done is another thing, because frankly, it seems like removing regulation is one of the hardest things that we ever do. It's just always easier to say, well, just put more money in. I hope we can do this. I hope we can do the latter.
Ms. Rodriguez, do you want to take on this issue of Medicaid? I know that's often brought up in the context of rural health care, expanding Medicaid. What do you think of, what would that mean for a rural hospital's bottom line?
I mean, expansion of Medicaid or any kind of health insurance is good if it's going to be of value, because whether it's Medicaid, you know, again, it's what we get reimbursed is very little. You know, even with the exchange, the market exchange, those plans that are out there, there's various plans and levels of plans that, you know, patients have the ability to purchase. And so basically they may be insured through these plans, but they're really not. They're underinsured. And so what that causes for us is that, yes, you have a plan that we file your insurance, but you've got $1,000 deductible. Well, you're basically uninsured. And so they need to be able to offer these plans that cover more. Because what we're seeing in the market, and now more so, is just a higher level of an insured. Yes, we've got those uncompensated care monies that we can apply for, but it's still, a drop in the bucket when it comes at the end of the day. So.
In our last minute here, we have a couple of questions about access to mental health services in rural Texas. So I'm just going to combine them all and ask if any of you have thoughts on the best way to address or to ensure mental health care access, and again, quality health care access in rural Texas. It seems like some people are asking specifically about far west Texas, but statewide.
Well, I'll throw out telemental health as well, because really your only choice is either you're bringing the professional to the patient or allowing the patient to travel or communicate electronically, and the fastest likely best way is to allow for the telemental health.
I think so. I agree. I think telehealth will be big, and also, I'm actually very interested in this as a prior military veteran. I deal with a lot of patients with post-traumatic stress, and I founded a company called liveclinic.com where we're providing this services in rural Alaska. And I think in addition to the telehealth, there's the infrastructure that underlies that. So if there's no rural broadband and there's no high-speed internet, the telehealth will be difficult to implement. So I think the whole infrastructure of high-speed or high enough speed Wi-Fi and internet, and that with telemedicine, and then access to people, and then being able to transport them out. And then again, as we implement these things, we worry about cost, which we were worried about in the last question we asked. And I think for the legislators or anyone looking at these costs, in my mind, you look in two patterns. It's painless and painful cost control. So painless is it does not affect patient care, maybe administrative costs, we can cut those. Painful cost control is, preventative health and things like that will actually affect patient care. So I think we cut the painless costs, and then we hit rural broadband and implement telepsych.
And I do think there's an understanding from the legislature now that rural broadband isn't just something that rural people want, that it is it's almost like a utility now, like electricity and water.
Yes.
It is a necessary thing. And so I do think that is a big part of what the legislature, I hope, will do next session. So.
Well, I'm sorry to cut this short, but we are out of time. Thank you all for tuning in, and thank you so much to Dr. Bose, Ms. Rodriguez, and Representative Frank for joining us and sharing your insights.
Our pleasure.
Thank you.